are very fortunate that he has been guiding and advising us as a member of our academic council. And today only, when we were having a cup of tea, he readily agreed that he is more than willing to give us more time for promoting our academic and research activities. So, sir, we hope to see you more often with us, guiding our faculty. We also have Dr. Piyush Sani, who's a colleague from my specialty, GI surgery. He was the head of the Department of GI surgery at the AIIMS, New Delhi for a long time, recently finished his term, and now he's the chief of academics at the Max Hospital at Saket in New Delhi. But why he is here is because of his expertise and experience in publication and journalology. He has been the editor of the National Medical Journal of India, which is the equivalent of BMJ as far as Indian scenario is concerned, and is now the emeritus editor. He has been the president of the International Association of Medical Journal Editors. And on a personal note, for me, if I have any doubt, any question, any dilemma related to publications or journalology or editorial process, he is my gold standard. So I'm very happy that we have these three eminent experts. And once again, I would like to thank Dean Research, Dr. Aparna and Dr. Pragati for thinking of this session. And I sincerely hope that all of us, including myself, will benefit from this session. Thank you.
Moving ahead with the program, may I now invite Dr. Nikhil Marwa, Dean Research, Mahatma Gandhi University of Medical Sciences and Technology. Dr. Nikhil is Professor, Department of Pediatrics and Preventive Dentistry, Mahatma Gandhi Dental College. He is an Assistant Secretary to Indian Society of Pedodontics and Preventive Dentistry, Member Science Committee, International Academic of Pediatric Dentistry, Editor-in-Chief, International Journal of Clinical Pediatric Dentistry, which is PubMed and Scopus indexed. He has more than 20 books, author, and textbook of pediatric dentistry, which is prescribed by Dr. Nikhil Marwa, and co-author of more than 20 handbooks. To his credit, we have more than 75 international and national scientific publications. Over to you, Dr. Nikhil.
Hi, very good afternoon to all of you. And before I start the program, first of all, let me thank all the PhD scholars specifically who have taken out time from the schedule, because I see so many of you. A special thank you for considering my request and being here, because primarily this is going to be benefiting all of you most of the time. So Kapoor sir has already done the honors of the session and introducing everybody. Dr. Aparna will be introducing. And as sir said, this is just the first seed of a bigger tree which we want to plant. And we are now celebrating this particular day. 20th October is actually celebrated as Evidence-Based Healthcare Day. So this program is in line for that. And MGMST is a proud ambassador of this particular program. And this is in association with Joanne Biggs, University of Australia. So I think everybody should give a big hand that MGMST is a part of as a brand ambassador for this particular event. So which is a big feather in our cap. And research cell activities will start going on, are always going on. And this is just a small initiative. And I am sure all of you in some larger or smaller capacities have been influenced by those activities which are being done by us. So without taking much time, and because we are already running a little behind schedule, most of the program has been introduced. I would again like to give a very warm welcome to our esteemed faculties here, and those who have come here all the way to listen, and especially to the three eminent source faculty who are going to now enlighten us about the subject. Thank you.
It's my privilege to introduce Dr. Vishwa Mohan Katot sir. सर को इंट्रोडक्शन की कोई जरूरत नहीं, लेकिन अगर कहा जाए तो सूरज को बाती दिखाने जैसा होगा, लेकिन मुझे टास्क दिया गया तो आई एम ट्राइंग माय हम्बली आई विल इंट्रोड्यूस हिम. डॉक्टर V.M. Katot sir served as a director for the institute at ICMR Jalma, Agra, served as founder secretary of Department of Health Research and Director General ICMR Ministry of Health and Family Welfare, Government of India. Sir, throughout his career, had several positions during 24, namely the ICMR Chair on Public Health Research at RUHS Jaipur, President, AIMS Madurai Chairperson, Lepra Society, and President JIPMER. Currently, Sir is an editor to the Indian Journal of Leprosy and President to the Tuberculosis Association of India. He has contributed over 350 publications in the developer of modern methods of rapid diagnosis of tuberculosis and leprosy, DNA chips, DNA fingerprinting methods, etc. Sir is the founder secretary of new Department of Health Research and DG ICMR, where played an important role in establishment of multidisciplinary research units, model rural health research units for taking the technology to people, and virology diagnostic and research laboratories in states and medical college, thus accelerating the research on environment health, tribal health, and health system. Recipient of various national and international awards, Fellow of all National Science Academies of the country, namely National Academy of Sciences, Fellow of National Academy of Medical Sciences, Fellow of Academy of Sciences Bangalore, and Fellow of Indian Academy of Science. Sir has done his MBBS from Shimla, graduated as a medical microbiologist in 1978 from AIMS New Delhi. He joined the ICMR as Talent Search Scheme Fellow. So we welcome Sir for delivering his talk on Introduction to Evidence-Based Practice and Systematic Reviews, Significance of Evidence-Based Healthcare. Sir, the presentation. Screen sharing.
Yeah, he will. So, शूट का नेटवर्क होगा कट रही है
Participants, participants. Hello.
ये वाला तो ठीक है स्टार्ट कर दूं प्रेजेंटेशन ये आ गया इसमें आ गया ना यस
उसको भी रिड्यूस कर दीजिए खाली डॉक्टर साहब का ऑन रखिए वीडियो सिंगल ना सिंगल वन
ठीक है थैंक यू वेरी मच एक्चुअली
हम विजिबल हैं सर
आगे
विजिबल हैं हम
नहीं कोई बात नहीं लोग It's a pleasure to be here this afternoon. Certainly meeting some old friends and again very senior colleagues like Professor Sani, Professor Kapoor. Nevertheless, the younger one also matters, Dr. Shoban, they are people for future. But faculty of Mahatma Gandhi and even the research scholars also. When I think this, when I was invited for this workshop, I didn't know what I'm expected to talk here, because this is an area which I have never talked. I would have delivered hundreds of talks, but I was never invited to speak on the systematic reviews of its significance. I thought I'm coming as a listener, but still I will be listener, no problem on that. But I'll share some of my perspective, which I think was in the mind when this topic was assigned to me. See, most of the things which I tell, they are my personal observations, my personal perceptions actually. Professor Kapoor gave you an idea what is the expectation from you when you are actually being, I think, strengthened to write systematic reviews, meta-analysis. I think the very specific goal of empowering the faculty and also the scholars also, because I certainly this is an important aspect. But I think beyond that, why you're empowering the faculty, because not only for writing your reviews, but then you have to create a new generation of people, strengthen those people who can really interpret what the systematic review is actually, what is the different level of evidence is. Because quite often we read, we quote, we don't really assign the appropriate importance to that. And so I think the medical students actually who pass out from this institution, if the faculty is strong, faculty is writing, faculty is in the grip of the knowledge, then you train your junior also, you train your next generation also appropriately. Now, what do you want to empower? We want to empower for all aspects of health actually, because we want to empower the country actually. Health is a fundamental right of every citizen. So that means you have to provide the best services to them. They should be a good quality and good access also, both things. Only then you can make the people healthy. If you look at India, that's a scenario. After 78 years of independence, India has moved a long way. We have world-class institutions, both in the government and private sector. Impact is also seen actually in all parameters. What we were at the time of 47, what we are today actually. And when I refer to the previous slide, look at a board committee report. All this quoted by all of us, all medical people. Sir Joseph Bohr was the 1902 batch ICS officer, one of the, I think, brightest bureaucrat this country has ever produced. So he was the last health commissioner of the British India also, and that led to that Bohr committee report. Not knowing that in 47 they are going to depart actually. He is Indian actually, a Nashik-born Christian, but I think one of the brightest characters. If you read his book, he has analyzed what he really expected, what are the gaps for the health. So today, when 78 years later, we are trying to fill those gaps only. We understand what the problem is. So we have achieved success, creating world-class institutions, more than 800 medical colleges, and a huge number of the private setups, which may not be medical colleges. But the point arises, is that success accessible to all? Answer is no. India suffers in a big gap, So the large section, the subsection of society, which live in very poor conditions, with limited access to the modern and evidence-based healthcare. They get something, but need not be evidence-based actually. Because as such, the system is weak. And whatever filters out to them is also further weak actually. So that means this is a question of the management part. But the second part is even the centers of excellence in this country and many reputed hospitals, the clinical practices may not always be guided by the principles of evidence-based medicine. They do what was being practiced, whatever their expertise there, or what they think is important, but not necessarily that is evidence-based medicine actually. That's today's India, 78 years after the Republic is born. Now you look at the historical aspect, the clinical practice, public health interventions, they're based on the robust evidence, have been found to be generally coming with the good outcomes. There's no doubt, there are hundreds of examples. Even if you take the independent India's example of iodine, actually, that study was done in Kangra district. They found what the problem is. The intervention also was done in Kangra district itself. And that led to a policy change by which millions of goiters would have been prevented. Impact is huge actually. Again, those studies were led by one of the AIMS directors, actually. He later became the director, Professor Ramalinga Swami. So the work done by him, his group, he later turned to a very important pathologist. But then we had a team of the clinicians, the team of the public health people in those studies which detected the problem, analyzed the problem, and led the intervention also, the first one. And it was public-based intervention, actually. So that's impact is there even today also. And that was evidence-based. So that policy change was not only some conjecture, actually. It was not only a small study. It is a huge population-based study. So I think that was a huge, you can give so many examples of the vaccines, so many different even the surgical procedures also being introduced, even the other method of diagnosis being introduced. So I'm not going to talk on that, but that means wherever the practices have been introduced based on the solid evidence, whether it's a public health or a diagnosis at a clinical level, I think they have made a huge success. So effective, safe, and cost-effective interventions are thus appropriate strategy. I don't think there's any doubt on that part. The significance part, which the one word was put into my title, it is very clear actually. So you can give a large number of examples. But over the centuries, medical practice has been by and large based on the experiences actually. That is evidence actually. But however, the vices which and the opinion of the dominant experts and the bodies that have been mostly influential. This is a fact actually. This stays even today. Why I'm talking this? When I think the younger generation looks at the guidelines by so and so, guidelines so and so, you should not blindly accept that actually, because quite often it is led by, I think, very dominant voices. And those dominant voices may not be objective. They get the ego, and after a while they push their doctrine. They want to say what I'm saying is right actually. And that's happened actually. And in medicine, this has been the most influential actually, because we are a hierarchical setup actually. And we look at the world from that angle. But this is on the other side. There have been people who have looked at the evidence also. There's nothing like that. Even in the history of the modern medicine also, there are examples, right from the 11th century onward. This is an example from Persia actually. After that, 16th century, 17th century, 18th century, large number of publications are there, where the doctors insisted on evidence actually. Whether it was the introduction of a treatment of the scurvy, whether it's some particular other procedure. These are all done, all led by proper people actually. So there's evidence-based examples, interventions. But the EVM which you are today discussing actually, which I think Professor Kapoor wants you to be empowered. There, this term, I think, evolved in the last 60, 70 years actually. And in those 60, 70 years, how the evidence is to be analyzed, what is good evidence, what is the bad evidence, what is the substantial evidence, this all came that way only. But the earlier 1990s, I think that's everybody, all the people who would have read that actually. This is all McMaster's story from there, that university which was building their epidemiological base. They came out with the definitions for what is the evidence-based medicine, what is the evidence-based practice actually. So they laid the criteria also. I think one teacher and one student, they made the difference. I presume all of you would have read that actually. But soon after, the India also started changing. India was also changing same time actually. And I'll show you the next slide actually, that there were examples from that era. 1988 onward, India was also changing. So several leading Indian institutions, I think they jumped into it a decade later, but the process had started earlier. So huge number of trainings have been organized. Several Indian institutions are part of the Cochrane India network. I think so. We are quite advanced as a expertise is concerned. So when you look at what you will discuss today, actually, I think where you start looking at, it is essentially meant for the clinical setups only. Thinking that from a perspective of I think a basic science. Basic science brings the knowledge actually, but you apply it only in the clinical side or in the public health side. There, you look at the best research evidence available. What is the best research evidence? I'll just share some ideas there also. Then that is to be coupled with the clinical experience. The guidelines are not the, I think, dictatorial way of dictating to a treating doctor. His or her clinical experience matters actually. Then the patient's values matter. You want to be treated that way or not actually? Because remember, that's something when I was sick, the choices left to me actually, what I wanted in the end. So ultimately, I knew one of the earlier very prominent Director General of Health Services when he was diagnosed with a cancer. And I think second or third day after that, I met him actually. And he took me to his room and for a cup of tea. But he was as shining as he used to be earlier. He had might have made up his mind that he won't go for chemotherapy. Whatever 6 months, 9 months, or 10 months are ahead of him, he wants to have a good quality life actually. So if you're thinking of just a prolonging somebody's life by 6 months or 1 year or 2 years, the choice is of the person actually. So that means it's an individual choice actually. Do you want to be treated that way? So that means these three are to be integrated. That it precisely makes these evidence-based medicine. So evidence-based medicine is not where you start saying with your data analysis or the systematic reviews or the meta-analysis or the guidelines. They are the starting points. They are the material which you should seriously consider. But what aspects you must look at it? You should look at the negative side. Strength is evidence. Strength is the way of doing it. But then the design of the studies may overlook the statistical heterogeneity that happens quite often in many of these RCTs. They are solid in what they do, but everything is not covered. You can't cover it also. So, but then that's for the number two, the data can be manipulated to obtain desired p-value. This is also known. You can make groups, subgroups in a way, and that you present in a way that you show the differences. So the statistics is that can be used to commit the sin also. Then the last point, which is more dangerous, is when these systematic reviews are published, then many people, because in our medical fraternity, somehow the statistics we don't like it as a subject actually. So we really don't know how to analyze it actually. What is the robustness of what particular method actually? So and we accept it. So systematic reviews as such also again the same story. So the guidelines also say the same story. What you have included, what you have not included. Okay. So ultimately, then ultimately this is fed to the doctors who are supposed to be making a decision actually. So I think you should not start with these systematic reviews only as a starting point, but not something sacred. That's the point which I want to make here actually. So they are dependent on the collection studies. This creates a problem because the selection criteria may be different actually. Many subtle differences may be different. They may be deciding the ultimate outcome. Authoritative aura which is given to such evidence may lead to significant abuses. That's what I want to highlight because this is something which when you walk on this journey, you write papers or you interpret papers, you accept papers, you teach this to your students, you must teach this to them. So that they should not be thought as a sacred part. The next is the publication bias. See, there's a publication bias, all of us know it. And particularly one factor is there, the positive results are more likely to be published than negative results. So most of the time, these are the positive stories which you find, and they also enter into your systematic reviews. So ultimately, whatever you put is all there actually. The same, your AI will also tell you the same because the same will be in the database actually. So clinicians have a little room for judgment many times if you dictate too much on the guidelines. Inadequate respect for the choice of the patients also in those decisions. Many studies do not adequately cover aging population. Those groups are mostly excluded from the studies. You say 18 to 65. You say this to this group. The people who are going to have a large number of comorbid conditions, they are not there actually. And they are one disease, 2 diseases at a time actually. You have not looked at other one, the person who will have 5, 6 conditions at the same time. So I think all those factors, when you analyze data, when you write reviews, you say, are they being taken into it? If not, you must emphasize in the end, they are not taken into consideration. So that's nothing, no wrong actually, not your fault actually. But the informed decision is not blind. That is based on this is the merit and this is lacking. So ultimately, this is a question of a practice on somebody else actually. So that matters. Now the next part which in this system is the level of so may not wait. Large number of be published. 94% had come from individuals actually. Now, why excluded? Because I'm aware of those studies. The fellows have no excuse because I think they want to exclude that purposely actually to highlight a particular point of view. So this system, the bias in the people who carry out these reviews that predetermines the course on you walk through. You should not do that, I tell you. And the people you will start writing or you start reading, please look at that. Any groups have been excluded deliberately. Any studies have been left out deliberately. There should be a reason for that. Why you excluded something? Cochrane reviews, by and large, they don't do that actually. I found a very few defects with those reviews. I think 1% of them you find problem there also, but most often there's no trouble. For other systematic reviews, you must be cautious to interpret, cautious to look at them. What is the material in that? So I think that level 1 evidence also may not be sacred evidence actually. I say the systematic reviews are the meta-analysis, they offer you the best possible way of analyzing, but they are not sacred. I've already made a case for the negative side actually, because that cautious part in your brain will tell you you'll do a better job. It's nothing to say that process is wrong, but you do a better job. Again, on the level 2, level 3, level 4, level 5, these evidences, I think Professor Kapoor has alluded to them. You will discuss about them again and again. They're all publication. I presume each of you know all of them also. See, lowest level evidences for the expert opinions from respected authorities on subject based on their clinical experience. Unfortunately, that dominates. Because I have experience, because I'm telling you because I have my own personal experiences. My personal experiences have been mostly from the 2 diseases, leprosy and TB, which I've been associated with. My life's 5 decades I've spent on them only. So there I know that what has happened actually. I know with the number of them when I was a policymaker in the center that to which guidelines to accept, which guidelines to be incorporated, then I knew what happened, but how the things go wrong. For example, for leprosy, the multi-drug treatment came in 1980s. Those WHO-led studies, they have very limited data on mice. There were no clinical data actually to support. And they introduced to the whole world actually. They made the 1 and 1 plus 1, 3 and done it. Some arbitrary figures, some few cases done in somebody in Africa, that's all. So no large scale data, but they were in a hurry to stop the transmission of leprosy. They wanted to bring down the numbers. And people like me were critics. I thought there's no science. How you could do that? So I was used to write long papers on them, protest on them. But unfortunately, I was wrong. Actually, later on, because they had a very public health motive in their mind. They didn't want to harm, but they wanted to not wait for more studies and large number of studies and wait for studies and then go for something introduction. And they were right. And with that therapy, they could treat millions of the people. They could prevent disabilities. But then the trouble was, they set a 6 months like a cutoff. By 6 months, there were large number of people who were still active actually. So clinicians were not convinced. Patient was not convinced. So it's not an unpopular thing actually. Many of them will subside of its own, but it will take a long time. But my wife is my wife is a clinician actually, and she was leading many of these studies actually. She came out with the solutions for those groups actually. Add this, so that will bring down the activity. Add this immunotherapy, that will bring down that clears everything out actually. The bacteria, like living bacteria, dead bacteria, everything. So point arises, they have solutions to do everything. But many of the time they won't go for them. But you should, as a scientist, as a teacher in medical college, you should not be accepting straight away. Because you are the people who will really lead the show actually. So I think the onus lies you not to follow. It lies on you to dissect and then accept. I have another story. This is the last part which I am talking about. They're changing the therapy in tuberculosis. Many of them you would be knowing when it was a DOTS came, it was an intermittent for 4 days a week actually. So every day it need not be the drug need not be given actually. But then they discovered, particularly for the HIV TB cases, they discovered that relapses are very high in such regimens. And they also showed by a daily regimen, relapses could be brought down to negligible levels. So they have the evidence for the HIV TB. And now they wanted it to be introduced for the all TB patients. Now because the purchases in the federal government, I was a secretary health research also. So the joint secretaries on the other side, they said they will not accept the recommendation of the DGHS because there is a secretary health research available there. So let's say go to his division.
Thank you so much.
They gave me the evidence. They had a solid evidence.
Thank you. Happy Diwali.
Change the evidence in case of the HIV TB cases. There the daily regimen had a clear edge. But there was no evidence on the other side, neither positive nor negative. Only evidence presented to me was the DGHS said that they have collected about 150 professors of chest and TB and medicine who came in one meeting of 2 days. And they told that the alternate day regimen doesn't work. And the best part is to go for an daily regimen. Now, daily regimen means double the expenditure. Then he said, okay, the resistance will be high. I said, where is the data? No data. I said, if there is no data, this is not going to happen. That's all. So that means I was very stickler of his evidence-based practice, actually. So what they did, they waited for my retirement, actually, 6 months. So okay, they brought to the next secretary, actually, and they got it. Okay. So even now, 10 years later, there's no data to show that they made a better choice. Presumably, they might have. I don't know, but how much it increased to the safety profile, how much it added to the betterment, how much it reduced the drug resistance, I don't know. So question was, the decision was not evidence-based, follow-up is not evidence-based, and 10 years later, the India is still at the same stage, actually. So the people are implementing something which they don't know whether they're doing a better job or not a better job. So that kind of thing happens for most of the diseases in this country. I think, so you are against up a ball. So when you are in a system, I think you will be lucky if you belong to a specialty where there's a little more respect for the evidence-based practices. But the fact is, on the government side, is nil actually. They collect a bunch of people who are maybe many of them are good also. I'm not saying they are not good, but they are their impressions. If 150 professors are talking something, why they couldn't publish actually? Why they couldn't collect the material to publish? Why they could not dissect the evidence? But they are there to act as the expert actually. That's the beauty actually. But you should not be like among them. Now the level of recommendation, which again you will have to analyze. The first part is which paper to give maximum importance. And I said very clearly that what you are talking today, what you are going to do today. Take 5 minutes more, sir. 5 minutes more, yes. So, so far what I'm saying, what we're going to do, we have to empower yourself to write good systematic reviews, then interpret good systematic reviews, and then to make a choice. So I'm making case for up to that point. Now it comes the level of evidence, level of recommendation. Based on these systematic reviews, you come to a 4 kind of recommendations. Some label even 5 also, but I think many people, they mention 3 only. The good scientific evidence, which benefit is more than the risk. Again, which is a fair scientific evidence, which again tells you the same. The third one is a fair evidence, but the risk and benefit almost are equal to each other. But the last one is, where the scientific evidence is lacking actually altogether. It is not there. So I think when you make a choice of you want to consider something for your clinical practice or for your public health recommendations, you have to look at the A and B with a seriousness. But you should look at what? That does it cover all the diverse population groups you are interested in? Like the geographical, genetic, age, gender, comorbidity, have they been taken into consideration? If not, that is a work still pending. That you must emphasize, and that where you should decide what you want to do as a scientist, what you want to do as a practitioner. This is one thing, another interesting thing. This is evidence-based medicine versus medicine-based evidence, which, this term I again read in one article in 2017, this Horowitz and Singer's article, very nice one published in the Journal of Clinical Epidemiology, which again caught my imagination at that time. So what we say, if you look at evidence-based medicine, it gives you something which is maybe good for the population, which you use in the public, in that domain. But one side doesn't fit all. And when as a doctor, what do you want to ask? Your question is, will it fit my doctor, my patient, or my group of patients I treat? There, which may have their own distinct biological, biographical profiles, actually. I think this is a question which is of importance to every clinician, actually. Should I adopt it? Should I not adopt it? So this, they called it medicine-based evidence. That means you should match the personalities, you should match the profiles, and then decide. It was possible earlier also by statistical the numbers, but with the AI-based tools, I think it can be much better done, but objectively done. But then you have to define that also. You have to really write all those parameters. So clinician and public health experts again need to be watchful, as practice of this has been corrupted by corporate interest, field regulation, and commercialization of their academia. So that's which group, who is publishing what. Even the systematic review also may be colored. So that you should listen that who are the authors to that. You must listen to that. Look at go by the motives, whether motives are right or not right, actually. Look at the India side, which I'll take a minute to finish it off. India is huge population. Most of the people are not informed. They don't have the capacity. I think they can't analyze. They don't know how to analyze the data and look at it. They're two very distant. Life is very different. Now, this 1988, it began, I said. Many people are being trained by that people. But I think I read actually about 1998, or 60 people were trained from good institutions. But the EBM, I think, first workshop was in Kodaikanal, organized in 1995. We have AIMS was the first center. Now there are 10. So I think the Cochrane that story also evolved here. Number of associations like Indian Academy of Pediatricians, JAPI, IDBL, I think they gave a lot of importance to it. But I really don't know how far it is uniform, because I have no experience of others. So I think the practice, as far as I look at it, is not so strong. So when you look at future, today we are walking on a journey out to empower yourself to write and interpret reviews, systematic reviews. But then, look, what for are you doing? That will be with the goal of evidence-based policy decisions to be taken by state and central governments for the needs of the people in different sections of society. If you were the rural side, the Department of Health and Research, we established 38 units across the country. They are in all states, where the ICMR, State Health Service, State Medical College. Now this is open to the private side also. Savita Medical College becomes the first private medical college to get such a unit of multidisciplinary research unit also. This whole story began in Ghatampur. Again, this was a story led by my wife at that time. She created this unit. But ultimately, now this is in 38 states, where you can decide what is to be done, which topics, which area. So it's an epidemiology at local stage, interventions at that stage. So whatever you would have read from the public health, I think the systematic reviews, the first place you apply there actually, and see for yourself, is it adaptable, it is workable, does it give the same results as published? So then you introduce. And then second step is the appropriate health technology assessment. Is it a cost-effective way to do it actually? I think that's the one point which is equally vital when you want to do at a public health level. The last component is medical colleges have to be the fulcrum. So starting this movement here, I think will definitely help, because you are producing a large number of medical graduates actually. If this is a concept, even once or twice or 3 times, they also join the workshops. Your postgraduate join the workshop. This word start ringing into them. Those limitations, the advantage, disadvantage of not only how to do it and publish, but how to analyze, which is a good review, which is a bad review. I think what is to be taken into policy, but more science is to be done. I think this all to be done at the medical college level. Unfortunately, at the moment, there are very few medical colleges who are into it. I think these are all elite institutions. They're still playing a very, very pivotal role. AIMS, PGI, New AIMS, SGPGI, JIPMER. These institutions are playing a pivotal role. I don't think them, and I can't fault them. They have done their best in the last 30 years. They're doing actually. This is happening. Funding agencies are also providing funds. If you want to do something on that, they are providing funds. I think issue is these practices, they are social transformation. things won't change overnight. So I think for the youngsters who will start the process, they must not be deterred by that, many people don't use it. This is a social transformation. This is a change which will happen as the time moves. But I think we must push. So journey has begun, but miles to go. I think we see even 30 years later, we are in infancy. I think that's phase has gone too far, but we will change. I think this workshop here, I think will again ignite a change, which I hope that I think this thought, this attempt will, I think, lead to a start of a process where you will keep on debating, keep on getting empowered, and keep on empowering your students in the process. Best wishes.
Thank you, sir, for the insightful and informative session. Your expertise and experiences shared today have been truly valuable. Thank you, sir. It's time to invite our next speaker, Dr. Pragati Kurani. Dr. Pragati Kurani did her MDS in prosthodontics from Bharatiya Vidyapeeth Dental College, Pune, and is working as a professor at Mahatma Gandhi Dental College and Hospital. She is also the editor-in-chief of the Journal of Mahatma Gandhi University Medical College and member secretary of R&D Cell. She has authored books on research methodology, which was launched by the Honorable President of DCI, Dr. Mazumdar, in 2020. Several publications to her credit and has authored chapters in books, has been invited as a guest speaker at various national and international conferences, actively involved in conducting and teaching systematic reviews. She has published several systematic reviews in reputed journals and has served as a brand ambassador for World Evidence Healthcare Day in 2023. She has presented her overview in Cochrane India Network Conference at Lucknow in 2024. Her research on nanoparticles in denture-based resins has received a research grant from the DBT Government of India, and a postgraduate student research on dental implants has received a research grant from ITI India. Her scientific paper at the National Conference of IPS won the prestigious Dr. G.C. Das Memorial Award in December 2020. Also served as a scientific chairperson for the 43rd PG Convention of the Indian Prosthetic Society in 2021. Dr. Pragati is here to speak on the topic conducting systematic reviews and meta-analysis, a step-by-step approach.
Thank you, ma'am. A warm welcome to all respected guest speakers, Dr. V.K. Kapoor, sir. It's really a matter of honor for me to talk here. And on an afternoon post-lunch discussing systematic reviews, you all are really motivated. So I'm grateful for you all to join me. I'm talking about the life cycle or just a step-by-step approach. Of course, half an hour cannot do justice to this huge and extremely wonderful topic or this type of research, but I'll try my best to fit it in half an hour. I would want to begin by wishing you all on the World Evidence-Based Healthcare Day, which comes on 20th October. And this time, this is really a feather in our cap because Mahatma Gandhi University of Medical Sciences and Technology, under the able guidance of our Vice Chancellor, sir, and our Pro-Vice Chancellor, sir, has become the brand ambassador for this year. So this event is actually showcasing on JBI website along with bigger names like Cochrane and others. So we are in this initiative, have started off with this particular initiative by the Research and Development Cell and the Medical Education Unit of this university. I also have my little personal interest in this because as the editor, I have seen that people are submitting reviews which they call as systematic reviews, and I have to just simply reject them because they don't fall under any categorization of a review. So personally, I feel very bad. And then I thought that probably we have not equipped ourselves enough. Probably we are not trained enough. So rather than, just blindly rejecting, let's empower everybody and let's understand this need of the hour. So well, yes, each year more than 1 million articles are being published. A very simple topic like tooth loss and nutrition. Also, there's a disclaimer, I might just land up talking a lot about dentistry because that's my background, but That's how it is. So tooth loss with nutrition, if you type on PubMed, right, it from the beginning, you have almost 800 articles. And even in the last 10 years, there are around 500 articles on this topic. So if I want to analyze this topic as a clinician, as an academician, as a researcher, as a human, it's impossible to read and come to a conclusion after reading 500 articles. That's the first problem. So there's an explosive exponential growth because of the academic pressures, and more so after COVID. Also, we have to keep pace because technology is moving so fast. So there's not only a huge volume of things being thrown at us, also it's very technologically advanced. So we need to be keeping pace with it. And how do we read thousands and thousands of articles? Where do we get the time from? And where do we analyze these articles to come to a clinical decision? Do we search? Do we read? Do we have that much time to read? And can we interpret all of that data that comes if you just type some research problem on the net? It's not possible, I feel so. If you are a young researcher or a person who's a young clinician, what you would do is, that's how I see my residents do. They immediately type on Google and Google throws some chatbot on you. So either you go to ChatGPT, you go to Meta, or you go to Gemini and you ask some question to them. And if you are a more learned elderly person like me, perhaps, you go to more reliable sources of information. But both these sources are something to think about because they are all AI, there's all algorithm working over there. They are not reliable. In fact, Gemini and others give you references, but those references are host references. If you actually go to them, they may not even be there. And you might land up giving your treatment decision based on something that you casually asked. That is the problem, and more so for the younger generation because that's how they're growing up with the phone. So even PubMed is a problem. I used to think that I published an article and it's come in PubMed. But if you type my keywords, my article lands up in the 4th or the 5th page. It's not even visible. So I started thinking, why is it that there are certain articles that are on the top and mine are, below down there? What's the problem? So PubMed is also an algorithm which works on keywords. If your keywords matches with a particular article, that's how that article appears right on the top of the search. It has nothing to do with the quality of that publication. It has nothing to do with what it's giving you as an information. So there's no quality that nobody's talking. There's just quantity and some algorithm which is working and tweaking with our minds. And this can be dangerous. So this is where the concept of evidence-based medicine and healthcare comes in. And Sir has already given a lot about it. So there are 3 pillars to it. The first one, of course, is the starting point, as Sir said, that evidence becomes the starting point. You need to know where to begin, and that should be based on evidence. Then, of course, there's clinical expertise and the population and so on, the local population, patient values, and so on. So we are here to speak about the first pillar, that is where to start. And the decision needs to be informed. The decision needs to be based upon evidence. There are bigger players in the picture. There is JBI and there is Cochrane. They are international organizations which are working. They have their networks. So we already mentioned, and I'll also tell you. So Cochrane India has its own network with some few prestigious colleges. I don't know why their gates are not open to the others, but that's how it is. And JBI. So they regularly do these workshops and they have very active groups which you all can join if this is what your interest is. So hence systematic reviews and meta-analysis, because they provide the highest quality of evidence that is available and known today. And I'll just give you the basic concept and then we can run through the steps. Because if you just understand why systematic reviews, then the steps will come rather easy to you. So the first thing about systematic reviews is the analysis of the quality of the evidence. We have a very extensive lecture on risk of bias and quality assessment. So it's not just data thrown at you. The data is analyzed in perspective of the quality that's available. So it's good to say treatment A is better than treatment B, but what was the quality of the evidence on which this decision was based? This particular aspect is not done in any other form of research, publication, discussion, editorials, nowhere. So the quality of the evidence is not assessed anywhere else except systematic reviews and meta-analysis, which is why it puts you right on the top. And the second part of it is publication bias. Like I said, you can't read 800 articles. I mean, a clinician can't read 800 articles, but if you were to do a systematic review, you have to read those 800 articles. You can't leave them out. So rest assured, a systematic review has read those 800 articles and then written an answer in one sentence for you. That's where the credit to systematic reviews come. And this I can say out of my own experience, because one of my systematic reviews got rejected because I left out one article which the reviewer was able to find. So because one article was left in the search, the article was rejected. So that's how robust the methodology becomes, and hence the evidence becomes, and hence the decision based of your treatment can become. So that's the onus, that's the credit of systematic reviews and meta-analysis. So it filters everything because the research question is very crisp. The criteria are very crisp. Like Sir said, that it's too crisp, maybe. But when you have the other two pillars of evidence base, if it's too crisp, you can use your expertise, you can use patient values and come to a conclusion. I will quickly go through some fact checks of systematic reviews to make this little more interesting. Firstly, it is a secondary research. You are entirely dependent on the primary researchers. You are not going on the field to collect the data. So if the data is poor, your result, of course, will be good, but it will be poor because the primary researchers were poor. But that also is a finding that, well, look, the research is poor on these articles, on this topic, please do better research. That itself is a finding. So it's a secondary research, it's also called as a desk research. It has, of course, the highest creditability in publication and scientific fraternity as of now. The clinician, Sir, has already said, this is another thing I feel, that you may be a clinician, but you must be able to interpret the extremely technical language of systematic reviews and meta-analysis. And believe me, it's not easy. It's of course required for academicians, PhD scholars, researchers. It's in many colleges, it's mandatory. The library dissertations have been replaced by systematic reviews down south, other countries. It's very time consuming, but in today's date, we can't afford this. I will come to that also later because I have experienced a problem regarding that. Sir said there is funding. I'm still to find funding. I think there is very little funding. ICMR once or twice comes out with some funding, but I'm not aware. Maybe DHR paper. Yes, sir. So
Don't use that. For developing the guidelines for systematic review, there is a clause.
there's a clause. So there is little funding. More so for private entities, but yes, sir, there is funding. And then there are bigger players and very active players. Sir has already mentioned names. Rishikesh doing that wonderful job. Cochrane India Network doing excellent job. JBI Amrita Center of Evidence Synthesis down south is doing a tremendous job. You have KGMC Lucknow, which is again a center of Cochrane India, doing fantastic. Global Center of Evidence Synthesis is a center in Chandigarh, PGI, again doing good. They do conferences. I think Cochrane India has its conference now in November or December. So there is something that's happening in India as well. It's not that. And they are doing, it's for us to join in the flowing river. We have guidelines to report, thankfully. It's not something we are working in the blind. So we just have to follow these guidelines. The Prisma 2020 is freely available. We have lots of learning resources. Even courses are available, which are available free also. This is a new finding because the government jobs now have a requirement of systematic review publication. So very recently, an MO for Rajasthan government had come out in dental, and there it was written that their requirement is of 2 published systematic reviews. So I think there is a lot of buzz that's happening around, and we need to pull up our socks for that as well. You need skills. Yes, you need a lot of skills, I would say. You should know how to use Excel sheets. You should know the AI tools. You should know good teamwork, keep the ego down, bring people together. And you need a lot of skills to do systematic reviews and meta-analysis. There are dedicated conferences in India with fantastic speakers. So all of those who are motivated, there's a lot that's happening. That little thing I found in LinkedIn just 2 days ago, where if you can see, it's a stipend paid internship in PGI for Global Center of Evidence Synthesis. So I think there are opportunities if we want to avail. Now let's quickly run through what the main body and content of my topic about systematic reviews. So the process is about collecting relevant information, leaving out what is not relevant so that you are able to come out with a conclusive answer. But in light of quality of the evidence. That is the part which we cannot leave out. So you can say something is better than something, but you have to also say how good or bad is the evidence. What is the risk that was, the risk of bias that was there within the evidence? Why do we require? Sir has already mentioned a lot of it. So what is required to conduct? You require, very important, a research team. Let me be very honest with you, it cannot happen by one person. You need to have a team of experts. And what all do you need for that? You need researchers, more than two, at least three. You need an expert also of that particular subject to go and ask questions, because there will be a point where you'll be stuck and you need someone to help you out. You need someone who can be what we call as a methodologist, who knows how to conduct systematic reviews and meta-analysis, because there are points where you get stuck and you want to ask this question, how to do it. You need to have someone on the clinical side, because just academic and theoretical makes no sense. You need to have someone who gives a clinical perspective to what you are finding. Librarian is also there, because the search strategy and search part comes through a librarian actually. So in other countries, there are librarians, qualified librarians who do this. I'm yet to, I think there are a few in India also, but no, not. Yeah, I'm yet to find librarians who do, but outside they do. And if you pay them, they will do it for you also. They will search, they will run the search, they will give you the CSV file and all of that. And definitely you need an able statistician who can run the meta-analysis if there is a meta-analysis involved. So without a team, it's not possible. That's the first thing. We also need access to databases, which is not free. And you should have access to certain AI tools, which are also not free. Because the whole world is using these. You can't do today's systematic review without AI tools. Humanly, manually, it's not possible. You will take 2.5, 3 years to finish it. By then, someone would publish it and it's gone. So you need to know these things today. You need to have the intellect to decipher data, to understand data, to put yourself into it. And you need the time. I think the most expensive thing should have been right on the top, because you need to put that kind of an effort. Mota to systematic reviews is divided into 3 parts. You have the first part, which is the planning, which is the conduction, is the second part, and you cannot miss out the publication part. So we have a separate lecture on the publication as aspect of it. And each part has a very important role to play. Let's quickly run through the planning part. It's just like any other research, but I think you should spend a lot of time and a lot of your brain space and intellect on the planning, because if this goes wrong, then the effort for the next 6-7 months will go waste. So the planning is very important, like any other research. So we start with the research question. You need an expert sitting with you in the team who can tell you, who would have read more maybe, where the research gap is already identified. So someone who's well read, or some clinical problem you've experienced or heard something in some conference, and you formulate it into a question and put it as an objective. Then identify the PICOs, and in each PICO, identify inclusion and exclusion. What is it that you're including? Who is it that you're excluding? Each one. So if it's population, whom are you including and whom will you exclude? If it's the intervention, what is the intervention? What, with definitions. What do you understand by nutritional status? What do you understand by nanoparticles? So the definition has to be very clear, even for the outcome measures. And then which is the study design? You will take only randomized control, or you will take only lab studies. You can't mix apples and oranges in systematic reviews. That's not possible. So you need to know exactly what you want. And ye karte karte, it starts becoming a funnel. It starts filtering and all the other irrelevant articles start falling out. Recent publications, this point I just wanted to highlight for students, because pehle it was possible to publish with one outcome measure. But now the systematic reviews by other countries are going haywire. They have so many outcome measures. I just wonder, do they not do anything else? Because it's so taxing. But today, if you want to publish a systematic review in a good journal, you should have multiple outcome measures in your analysis, which means a lot of hard work, more time, more effort. And I think it's not possible if you don't know the use of AI tools. So I think that's where they are doing all of this. The third part is the registration. Your protocol, if it's ready, there are certain websites where you have to register. Now, this is very important for you to, even when you begin, because when you've thought of a topic, you go to these protocol websites and see, koi aur to nahi kar raha. Otherwise, you are repeating and then they will not publish it. So it's important to go to a website, check the protocols that are registered, and also register yours so that the world knows that you are doing this. Now they will not do this. So register your protocol. The protocol registration, in fact, systematic review protocols themselves can be published. There are journals who will publish your protocol. So if you're able to make a crisp protocol, you can actually publish your protocol as a publication also in Q1 journals. This is a Q2 journal, but there are Q1 journals that will take your protocol for systematic review also as a publication. Now, search, I can never lay less emphasis on searching, whether it's your thesis, whether any clinical topic. But what becomes important in systematic review is that we, search multiple sources. That's what is the beauty of systematic reviews. So you will search the databases, you will go to conference publications, proceedings, you will go to the clinical trial registries and check. You will check the thesis also online. You will go to other resources like ResearchGate, Google Scholar. You will not leave a single leaf out because there will be people or reviewers who will search what you have done. And if they are able to find something, then it's gone. So there are AI tools for this also. Litmaps is free. You can use that. It will help you to identify articles which cite the same research topic. So make use of AI tools. This is basically done to completely cover the length and breadth of the available evidence today. So therefore, there reduces the publication bias. Now, here is another thing. In other countries, the bigger publications that are happening, they are also searching local languages. That's also included. So articles that are in Chinese, Japanese, they are also searched, interpreted, and included. If you do that, then you are able to hit a better journal for your publication, especially certain topics that involve public health and things like that. So that's as far as the literature search is concerned. You have to develop a search strategy for which you should know mesh terms, Boolean characteristics. So that's an entire training altogether, and that's where the librarians come into being. So if you have someone like that, then it's very good. If not, then you have to train yourself to do it. So we have the Prisma flowchart to help you out. It will tell you how many articles where you have searched. You have to report what articles were excluded and why they were excluded, because that is all transparency in systematic reviews. Okay, so once that is done, since a lot of databases are done, there is duplication. So you need to deduplicate the articles. This is also done by a tool. So there are tools available. This one is free, Ryan, which helps you deduplicate. So once the deduplication is done, then you go for the first round of screening of the titles and abstracts. Here you need two people. So you need two researchers of the similar. So you will do your pilot testing, training, and so on and so forth. So two people independently will read the titles and abstracts and either include or exclude the articles. This will be based upon the inclusion-exclusion criteria that was decided prior. And if there is a problem, which there will be, you need an expert. So conflicts are to be addressed by an expert. The round two, then once you have collected your articles, you will go to full text screening. Yani ki all articles at this point will be fully downloaded, fully read, fully understood, and then either included or excluded. Again, there will be two researchers who will do it independently, but you need experts for conflict, for solving the conflicts. So this flowchart will give you an idea about how to go about it. You will report those. Here is the reporting of the round one, then the reporting of the round two, what was included, then you will give the reasons why you excluded. In fact, you have to cite them also. So the reviewers can go and see which article you excluded and why. Then comes the data extraction part, where you extract certain everything. Then you extract the elements. Again, two researchers required who are pilot trained and tested. You will require experts for this problem solving. Ab yahan pe lots of problems come in, so you can have two experts who can tell you, because this makes the body of what you are trying to search. You need Excel sheets understanding, and now there is an AI tool. It is not free, but this AI tool helps you to extract data in matter of seconds. So all the extracted data will be, what basically it means is that all factors which will directly or indirectly affect your research question, they are extracted out of all the included articles. So authors, the country, the details of the population, the details of the intervention, the control group details, the outcome measure details, any other factors which will directly or indirectly affect your results, the results and conclusion. Here is where you need a lot of brainstorming. You need experts to think what data you want to extract, which will come out as a meaningful answer to the research question. Like I said, if you did use AI tools, it's faster. And I think that's what the rest of the world is doing, because if you don't do it, it takes a lot of time. But I see how fast people are publishing. So I'm sure they are using AI tools for such big researches. So if we don't use it, then again, we are left behind. Lastly comes the analysis of data. So data analysis can be of two types. In this case, either you are doing a qualitative analysis or a quantitative analysis. We use, that is the meta-analysis part. Again, for this, you need a statistician, of course, but you would need an expert to give you an understanding apart from the researchers who will analyze and pool the data. If it's qualitative, you are simply combining all those 15, 16 studies data together and coming to some kind of a conclusion. And it needs to be, of course, homogeneous. By now, the data will be homogeneous because you would have excluded things which are not fitting in your research question. It's important to understand the confounding factors, because any discussion without those things that are affecting your results will make a study poor. So this is what will come in the qualitative assessments. The quantitative assessments requires you to analyze data together. The lesser I speak on this, the better it is. I should leave it for more expert people, क्योंकि सर ने बोला वो नंबर देख के ही डॉक्टरों को घबराहट होती है, मुझे तो होती है. तो ये ग्राफ्स हैं, फॉरेस्ट प्लॉट है, but I'm sure that when we do a detailed workshop, I will also learn much more. But yes, there's a triangle. If it crosses the line, it means something. If it doesn't cross the line, so it is the quantitative assessment, but not all reviews will go up to the quantitative analysis. So somewhere the reviews stop at systematic review because you don't have enough data. You don't have enough data to go to quantitative assessment. But if it is, then it comes to meta-analysis, which is what journals would. I mean, of course, that's what we want, right? We want to pull all the data together and come to a quantitative assessment. So the aim is meta-analysis, but if it doesn't so happen, you can just publish it as a systematic review. Step 9 and step 10, I will miss completely because we have very good lecture after this. And that is how the systematic review comes right on the top, because it goes through these vigorous and reproducible mechanism, which is very transparently reported. The more transparently it is done and reported, the better are the chances for you to hit a better journal, and more importantly, contribute something meaningful to the scientific community, which will benefit people. Like just Sir said, why are we doing this? Ultimately, it should help someone down there. So once we do this step by step, and you can't miss a step. So there's no other way of doing this. You would have achieved the answer to the research question you began with. You would have, in fact, identified the gaps in the existing research, and you will yourself recommend that this is how the research in future should be done. This is a very important part of systematic. In fact, that is one of the contributions of systematic reviews. It tells you, it gives a direction for future research also, which is fantastic. So if you just read a systematic review, you already know what's missing, and that's where you can start, actually. It also gives you recommendations for policy making. So if you read the public health side systematic reviews, there's a separate column for recommendations for policy making. So that's how beautiful this research is in its own way. Finally, we publish it and we put a crown on our head for what we have worked. This is a little run through of the same thing, all the steps that we have discussed quickly. So once again, I would thank you all for your patient listening. I would also thank Mahatma Gandhi University of Medical Sciences and Technology our Dean Research, our Pro VC Sir, for giving this opportunity to take this initiative. And I hope that we are able to together as a team get more good systematic reviews out of the university. Thank you very much.
Is there any place and value of a simple narrative review today?
Yes, sir. Narrative. So I should have started that way, where narrative reviews are there, but bigger journals will not take a simple narrative review. Maybe scoping review, perhaps. That's a start point. But narrative reviews now, sir.
What's the difference?
Sir, when we say scoping review, till quality assessment, we are doing everything like a systematic review. We don't assess the quality, but we do search. We don't leave out a single article. We do a proper search strategy. So we don't leave out any article and then combine the data qualitatively, but we don't assess the quality of the data. So we are not doing risk of bias assessments. We are not doing grade analysis for scoping review. So if it's a broader research question, then scoping review. Now narrative reviews, they will not take, sir. So at best, you start with the scoping review. If the research question is very broad, like now it will get accepted, BMC oral health. So the research question that we did was, what are the current herbal methods to treat peri-implantitis? So all herbal methods, implant coating, implant ke andar herbal method, gums, mouthwashes, but everything is covered. But no quality assessment is done, no comparison is done. But everything is covered. There's not a single article that has been left behind or a single intervention that has been left behind. But narrative reviews do not have this sequence. They are even less forgiving, and hence now the journals will not take it.
Exactly, post-COVID, it's a rapid review, madam. It's
Rapid review.
Rapid review.
So, sir, rapid reviews are living reviews.
Don't follow proper Prisma.
They will not follow, sir, because they are living reviews. There are different types of reviews altogether. So where you have a very pulsating topic, where interventions like in COVID, where interventions are changing very, very fast. So you need to upgrade it very fast. The data needs to be upgraded for clinicians to know what to do. Those reviews come under the category of living reviews.
Rapid review.
वो कोविड में था because इतनी जल्दी interventions आ रहे थे. But we should start with scoping reviews, sir. I think that is the start point. Scoping reviews, because they are slightly forgiving, because such technical things like quality assessments and all are not done. Meta-analysis, of course, is not done at all. So students can start from scoping review, then systematic review, and then actual randomized control trial. That is the sequence of evidence-based research. That's the sequence of evidence-based research. Thank you.
Thank you, Dr. Pragati, for the detailed and step-by-step guidance on SRMA. Your clear explanation and examples have made a complex topic more accessible. We appreciate your patience and expertise in walking us through the process. Moving on, we have our next speaker, Dr. Shobhan Babu Vartya, all the way from AIIMS Jodhpur. Sir has graduated from Telangana State and did his specialization from PGI Chandigarh. Sir is a pharmacologist and his research interest is precision pharmacology in diabetes, tuberculosis and latent tuberculosis, repurposing of drugs and clinical trials. Sir has, to his credit, many extramural projects. He has received research grants from ICMR. He has guided MD thesis and also has been the PI in some non-funded projects. He has been a Cochrane reviewer, member of the Committee for Tribal Health and Research and Satellite Center for Tribal Health and Research, reviewer of Journal of Pharmacy and Pharmacology and Oxford University Journal, Curious, PLOS ONE, and Indian Journal of Pharmacology. Nearly 100 publications to his credit, books have been authored and chapters co-authored. Sir is a life member of many pharmacological society. So we have Sir to present the topic on risk of bias and grade analysis.
Thank you, ma'am. Thank you for introduction. I really thank you for giving this opportunity, Kapoor sir, and the like when I was standing with them, I am very young and I feel like very, but however, sir, and their hospitality made me more comfortable here. However, thank you, ma'am, for nice introduction. Thank you, ma'am, for coordinating me. See, then when I came here, sir said that it is very new. I thought, well, it's nothing like there is need of expertise and all these things. I will make you more simplest way of how what we do. The two things it is clear that made by Pragman that it's a secondary data, right? We are pulling the secondary data, and we are concluding that whether we need to you can guide that this is the therapy is better or there is a need for further studies. That's what we come to know, right? When you are taking secondary data, we have to assess the data what we are published is of quality or not. Because the publication, when you see, there are so many information will be because there are multiple factors actually. Every information cannot be included. There is limitation in the words. So they keep only essential information. But when you are analyzing it, we are taking secondary data. So we have to look the what are the methodology aspect, how they publish, everything. And that makes comes the aspect of this one, risk of bias and grade analysis. I will be taking you slowly to each of these concepts, right? Right. As ma'am said, all these steps she covered very nicely. So I'm not going back again and telling you the same thing from question to the publication. All the aspects will be there in a systematic review analysis, right? So risk of bias, what it says actually, there are multiple ways to conduct the risk of bias, but here I am telling only for the Cochrane risk of bias 2 model because this is for RCTs. So because when you pull the data from the RCT, that gives a evidence of highest grade, right? Rather than pulling the data from case series, case analysis. So I'm not taking those things, but I will be telling you the Cochrane risk of bias 2 tool, right? And it has multiple domains, right? This risk of bias tool has multiple domains that I will be telling, and each domain will be supplemented with the signaling questions that give what they have performed. So I will be taking them also, right? And then the algorithm behind that one, they will compile and tell you that it is comes under the low, some concern or high risk of bias. And as assessor, you also has to do the same. When it is matching, then the pooled analysis, pooled risk of bias will be coming, right? So what are the different domains we have? Now, in a methodological, in generally, when we are doing the data, two components are important, right? Methods and results. Other things we pull from the other sources and we support our evidence, right? In methodology, what we generally do is, I'm telling about the risk of bias regarding the randomization studies. So generally, I will be restricting my topic to that area only, right? So was the any bias? Bias is a systematic error. It is not we mean to do actually. So errors happen actually during the study process. So bias which are arising from the randomization process, right? Are bias because of deviation from the intended intervention. We may be deviated, or because of missing outcome, right? Or it is because of the measurement of the outcome. When you are measuring the outcome, the modality of measurement outcome, or when you are reporting it. So there are multiple steps where is a potentially there is a bias will occur, and each bias results in the specific type of bias, like selection bias. When your randomization process is in, there is a trouble in that one. There is a process. Probably there is a possibility of selection bias. How it happens, I will explain you, right? Then when your intended intervention is somewhere problem, then performance bias will occur. When there is a missing data, attrition bias will occur. When outcome assessment is there, then detection bias will be there. Reporting bias will be there. These are the multiple bias that are potentially will be there when you are conducting a study. And we try to minimize as much as possible while we are conducting a original study. But when I'm doing a secondary data analysis, I have to see all this, they are how they minimized. If they minimize, then I categorize into low risk of bias. If they don't, then I categorize into the some risk or high risk category. So these are the three possible outcomes from my judgment, right? There is a low risk of bias, some concern, and high risk of bias. These are the three potential chances, right? Coming to each domain, individual I will be discussing, right? Risk of bias because of randomization process. So how we can assess? These are the three signaling questions that is present in the software tool. One is the allocation sequence is random, right? So when you are reading that one, they will be telling that they're randomly assigned into two groups. But how they generated the allocation, that is important, right? And what the allocation sequence was concealed, properly concealed or not. Concealed, it is generally, it is a way that when the patients enrolled into the study, before that, neither the investigator, nor the patient, or the assessor, or the outcome, everybody should not be aware that which part, in which group the patient will be going into, right? If you know, then there is a potentially there is a chance of bias will be increased, right? And if both are done, is the baseline characteristics between the among the two groups are similar or not? If I do some intervention in these two concepts, I forcibly introduce someone either, then what happens? The baseline characteristic will be deviated. Why we are doing randomization? All the known, unknown, confounding factors to be similar. If you are doing anything, then baseline characteristics will be changing, right? Just I will be giving you in detail that what are the different inadequate methods of randomization. Different methods of inadequate, because here allocation sequence subject to judgment. मुझे लगा इसको control group अच्छा है. मुझे लगा. It's not मुझे लगा. I have to be designed randomly, right? Participant preference. हाँ बताओ किस में जाना? इधर. Right, left. Okay. Then lab test reports. Okay. यार इसका anti-pro-BNP high है, इसको तो intervention group में डालेंगे. So it should not be like that, right? Similarly, theoretically manipulation. How it happens? Date of admission, hospital date, records based. So these are the potential bias will occur. So if you find something related to this one, we can say that it is having the bias randomization process. What is the best randomization process? What are alternate methods? Now, computer-generated random sequence generation methods are the best now. But randomization or RCTs are coming since 1930s. During that time, computer bhi nahi tha na. So they designed different methods like coining toss, shuffling. They are the techniques that to follow, and even today they are also standard only. Okay, and each technique there are pros and cons. That will be limitations, but however, still today the random sequence table or computer-generated random sequence generations, they are still considered as the gold standard of randomization. Now, once you randomize, patient will go enrolled, and patient and the here investigator comes into the action now. Right, this is a sequence generation is there. Now, the sequence, as per the sequence, patient will be going to the control group or the intended treatment group, right? So in the allocation sequence, what happens if you don't conceal the allocation properly? Properly means once the patient has been enrolled as per the eligibility criteria, he has to be, as per the sequence, we have to put it in the group. If before that only you know that, now the second sequence is coming is, if I say the half envelope or incomplete seal envelope, surgeons will be looking at the, okay, and seeing that isme to drug nahi hai, isme to dusri material hai. Then they can tend to, okay, postpone this patient. We skip this patient. Next patient will come. This is not a potential patient. So like that, there are potential biases will occur, right? So the purpose of allocation concealment is to prevent the selection bias. Very important. Okay? Allocation concealment is very important to prevent the selection bias. And there are different tools how we can do the allocation. It describes that the method used to conceal the allocation sequence in sufficient detail to determine whether the intervention allocation could have been foreseen before during the treatment. Right? Then if it is before known, then it is high risk of bias. It has been concealed after sequence generation, after enrollment, then it is low risk of bias. Right? If there is no information, sometimes information will not be available. Then what to do? We have to put it into some terms. Right? So there are multiple studies, data says that there are around 30% or 40% of studies, they don't have the concealed data based on the previous generated. Right? Then comparison of the baseline characteristics. Right? So in baseline characteristic, actually, there is some imbalance, potential imbalance will be there. Even though we randomize, we say that all the known, unknown confounding factors are being factored out. But still, there is imbalances will be there. But when I say there is something problem in the randomization process or concealment process, how I can say there is a different size groups, like one side 50-50 ratio. So there should be like around 50 nearby 50-50. If I say 30-70, there is a problem, right? Second, there is too much variation, right? Too much significant differences are present in the baseline characteristics. That is also a problem. Too much similarity. ऐसा भी नहीं है कि पूरा 58.4 years of age, 58.4 or 5. Okay, it cannot be like that. Too much similarity. So by looking at the data, we can safely say that there is a problem in that one. And then we can come to know that whether there is a randomization process done properly, allocation consignment is properly done. Yes. Is there any baseline differences? If it is no, then we can say low risk of bias for this particular component, right? For this tool. Then second component comes, that is our bias due to deviation from the intended intervention. Now we design the intended intervention, right? Now here actually there is two things are there. One is assignment, second is adherence. One is we are assigning to the patient. Now patient is adhered to it or not. That is also very important. Right? During assignment, it is again why we conduct double-blinded studies are more robust, because during assignment process, neither the physician nor investigator nor the patient are aware of the what type of intervention they are receiving. That's why their assignment will be clear, right? And adherence. If a patient knows that I am getting placebo treatment, in general tendency, what happens? He might not follow you on time like scale of follow-up. Or what he tries to do, he tries to take alternate therapies also. Okay, he may bypass the therapies what you are giving. So these are the potential possible chances, right? Just what are the signaling questions that will be generated in this context is what the participants are aware of the assigned intervention during the study or not. So in blinded study, it is clear there will not be a difference. But open label studies, there is a chances that what is clear? It's open label, right? They will be aware. If patient is blinded, it's the caregivers. We have a study now, it's an ongoing study where what we have done, we are recruiting the patient for the emergency. Both patient requires IV and oral therapy depending on the patient acceptability. So oral therapy, we made double dummy preparations that we can forego because it's blinded trial. But for IV, it is very difficult to make because some is going in infusion, some is going in this one. So what we did is we opened the service provider like staff nurses are aware of the intervention, but not the patient and the outcome assessor, that is investigator. We made so that at least we fulfill the criteria, right? And then now what happens if generally in this sequence, what happens to prevent the result from the impacted by one assignment mein kya hoga? What problems will come, right? There's a non-receipt of assigned intervention. Patient will say deny that one, right? They say switching to other arm. Patient say that I don't want to be in this arm. So I say no. If he asks me to change the arm, I will not going to change. If he goes to director sir, I will not change. If he goes to MLA, I will not change. If he goes to Trump says tariff लगाएंगे तो भी नहीं change करूंगा. Why? क्यों नहीं change करूंगा मैं? Actually, other aspect is that patient has a right to his choice to make, right? In a clinical trial, he has a right. He can say, I cannot be part of the study. He can go, but he cannot force me to do, right? So here, autonomy, patient autonomy is there. He can be denied or he can come out of the study. Okay, after that, clinician thinks that okay, this is approved drug, he will get. But he cannot ask me to change, but I will not going to change, right? Then is there any additional interventions he's taking or not? Those things will be observed. Adherence is another problem, is non-adherence, right? Because they think that anyhow it's a placebo, there is no point in taking the drug and other things, right? So these are the potential chances that bias can be generated. See here what are the potential biases can be generated? When you are looking at the already published article, you have to check for all these aspects. It is available, then okay. Then we say there is no potential bias. If there is, you think that you assess that there is a potential bias are there, then we categorize into high risk bias, right? Then again, sequentially, there are multiple steps will be right? Multiple questions will be asked. If these two questions are no, then these questions will not arise. But if it is yes, then these questions will arise. That case, is the deviation is because of trial context, because trial related context. If it is yes, then deviation can affect the outcome. Is that effect? If it is yes, then the deviation intended intervention balance between the groups. If the both groups having deviations requiring some additional treatment, then that will be taken, right? So these are the multiple steps that it is endless actually. If I take you risk of bias per se, it will take more time actually, but I'm skipping for this moment just to sensitize you. I'm telling each this aspect. Then third one is the bias during missing outcome. Missing outcome में problem क्या है? Which is a potentially causes the attrition bias, right? So what are the missing outcomes can be possibility, right? Why there is a missingness of data? Why it will be dropout? Certainly, no study will have 100% power, right? There's a potential dropout. But if the particular group is seeing the excessive dropout, right? Then what happens? Two chances. Either drug is causing more side effects or drug is ineffective. Drug is ineffective in placebo, it is potentially ineffective only, right? It is a possibility, right? And in the intervention group, because of side effects. So we have to check is that there is a balance or not, or what are the problems with the missing. So missingness, we have the chance, we can set up to 20%, 20% missingness, we can accept. After that, then we have to rethink and we have to grade down it, right? These are the questions that potential questions that I just keep here, right? Then bias of measurement or outcome measurement. There are like continuous variables will be there or dichotomous will be there, right? So differential bias will be there where we can generally recall related. Like, do you have the experience any side effects or something during that time? Okay, non-differential, where multiple factors will be affecting. So all these biases are outcome related. Those things we have to assess. And then we have the multiple questions for this one, outcome assessment also. For example, the method of measurement or outcome is inappropriate. They are negatively sending. See, here they are negatively mentioning. Is the method of measuring the outcome is inappropriate? If it is yes, then you will be having multiple questions. No, then we have limited questions. Right? In the sequence, we have to address all the queries, but it will automatically dim the other one. Because it is algorithm, right? It will dim the other one. So if it is no, then there is a multiple questions comes again, right? And then lastly, the bias because of selective reporting. So sir also said, right, initially stressed that what we generally do is the positive results we publish, right? And negative things, serious side effects or side effects, those things we generally categorize them into the table and send it. Or we can give into the one paragraph and we get it. That there are few reports of adverse events are recorded and they are not significant. But they don't give exactly that what is the grade 4 severity or grade 3 severity side effects and other things. Right?
Most of these biases are not mentioned on the ask.
You have to critically analyze and you have to observe those things, ma'am. Because they don't say. But when you read the article, that was there any deviation from the intended approaches like randomization process, allocation concealment, blinding is followed or not, missing data available or not, there is outcome assessment is predefined and they followed the same, or is there any deviation? Because outcome assessment, they don't keep here in the published article, but protocol you have to check here. In the protocol, they will be telling you in details about the the outcome assessment. So they are following the same or not, how they are going to balance the outcomes and everything. And you have to come out. That's the reason that when you are doing risk of bias, it is like you are reading the whole article and coming out and critically looking at it. Why we have to do all these things? क्यों करना है हमें? इतना क्या करना है सर? क्यों करना है? इतना नहीं करना है हमें. Why? Because when you recommend, after doing systematic review and you recommend something, either you have to recommend it that it is a high priority, strength of the, or you have to downgrade that. That is why you have to do all these components. So that is my second topic. That is, I guess these are the things I clear, right? So ultimately, for risk of bias, there are three components will be outcome. One is low risk of bias, second is some concerns, and third is high risk of bias. High risk of bias, clearly there is a deviation from the intended or the model, right? And in general, any component of these five aspects experience high risk of bias, then all the whole study is under the high risk of bias. ऐसा नहीं है कि थोड़ा सा तो रैंडमाइजेशन हुआ था, कोई बात नहीं, ऐसा नहीं होता है. थोड़ा सा तो सीक्वेंस में पता चल गया था, मिसिंग डेटा थोड़ा सा ही था, क्या है, ऐसा नहीं होता है. Even a single study, a single component is high risk of bias, then whole the studies become under the high risk of bias. Right? Similarly for some concerns and low risk of bias also. So just summarizing these things, I guess, right? Then the after doing the risk of bias, the another very important component is that after analyzing and everything, we have the grading. Now, grade is a very important because grade recommendations. You are making recommendation that there is a need for further studies or there is a sufficient evidence available to say that currently this therapy is essential for the moderate to severe disease or something, whatever the disease category is there, right? Now I will be telling you risk of bias. What is the role of the grading, right? In grading, risk of bias, if there is no, like if more than 66% of the articles having low risk of bias component, then we say that there is no serious concern. Okay, I accept it one. Up to 33% I have leverage. And I categorize them as without downgrading the evidence, I will keep it as such. If there is a decrease, like in between the 33 to 66%, then I downgrade by one step. Or if the more than 66% article are the high risk category, then I downgrade by 2 points. If I downgrade, then evidence what we generated is of low quality, right? One is risk of bias. Second important thing is inconsistency in publication, right? Inconsistency. These terms looks like a very ऐसा लगता है ना कि थोड़ा सा okay, right? कोई बात नहीं. However, I'm just simplifying you. Inconsistency मतलब consistency नहीं है results में. जो भी वो बोल रहा है वो उसमें consistency नहीं है. किस तरह से inconsistency हो सकता है? मैडम ने एक टेबल निकाला, बताया था कि ये तो बहुत ये अजीब तरह से टेबल है, ये समझ में नहीं आता, कुछ नहीं आता है. मैं बताऊंगा सिंपल कुछ नहीं है. इसमें क्या है? There are studies, their data, the pool data. We have complete analysis, right? Here, second in the total analysis, okay, right? Then comes the title, that is heterogeneity, right? And the overall effect. Two things are there. Heterogeneity is about the inconsistency, right? This heterogeneity generally pools it and says that whether the data whichever available is a consistent or inconsistent. Inconsistent होने के लिए बहुत सारे reasons होते हैं. मैं एक एक को आपको बता दूंगा, ठीक है? How it will look. But in generally, for example, if I look the data, if all the outcomes of each study is falling towards a similar trend, right? And CIs are overlapping here, right? And then the overall effect also towards the right effective side only. Don't worry, these are all my results only. Okay, उसलिए मैं कोई इसका ये नहीं दिया था, references नहीं दिया था. Okay, some are unpublished, some are published. I kept just for information, whichever feel like अच्छा जैसा image है वो सीधे दिखा रहा. Right? Now I will take you these things. So inconsistency when you are doing, right? Whether the point estimates are vary widely across the studies. ऐसा है कि एक towards the effect size, towards intervention positive, other is showing other side, right? So two diverse sides. Is the confidence intervals are overlapping or not? These are the things we check, right? Then we see that the overall effect of heterogeneity and what is the heterogeneity percentage, right? Here I can say that this is right. This is a heterogeneity that generally we see, right? And we downgrade according to requirement. Just I will be telling. Now there are two diagrams here, right? Now you see, as I said, one is point estimates. How is the point estimates in this diagram? They are, one is going towards the positive intervention, other is lying at the null effect, right? And is the CIs between the two is overlapping? Here, the confidence intervals overlapping between the studies? There is no. And the p-value is very small, right? 0.001. And the heterogeneity is 91.4, very high. So in such instances, we go to downgrading of the evidence. Now, this is the second one. There you can see there is a right overlapping of evidence, and more or less they are falling near the null effect and the other outcomes, and p-value is here is high, right? 0.7, and the I-square is 0%, right? 0%. So generally I don't downgrade here, right? Then again, second thing is if there is a heterogeneity, potentially there is a heterogeneity possibility is there because we are taking data from the various scenarios, right? So heterogeneity potentially available. because of the area of study and everything will matter, right? If I can address the heterogeneity, then I should not downgrade the evidence. If I unable to address it, then I will go for downgradation. If I could find that there is a subgroup analysis, this patient, if I take the CNS meds out, then the heterogeneity is coming down, then I can make sure that this evidence is valid and I will not downgrade it, right? Now, thumb rule here, simple, right? Don't think much. I simply say that I-square value above 50 is heterogenic, less than 50 is less heterogenic. You can limit your downgradation. Okay, there are multiple ways to tell that 50, 40, 30, 40 and everything, but simply, right? This I-square value you can check and you can accordingly downgrade. Third, again, this is another example I thought I can ask you people. Okay, just tell me whether I should downgrade in this aspect or not. Huh? पहले वाले में I will downgrade by 1 level, and second वाले में I will downgrade by 2 levels. Why? Because even though the CIs are overlapping in the first one, right? Even though overlapping, but the I-square value is 67% and P value is small, right? That's why I'm downgrading by 1 level. Here, the CIs are not overlapping and they are diverse sites, right? P value, I-square value also very high and P value is very small, right? So I'm downgrading by 2 levels. Now, third thing is indirectness. Why I'm telling? One is risk of bias, where we can downgrade 1 or 2 based on the number of high risk, right? High risk of bias category. Based on the high risk category, we downgrade it. Second one is inconsistency based on the heterogeneity that I explained you. And the third one is inconsistency or indirectness, sorry. Right? This indirectness is that because what we are generated data is secondary data, right? So we are getting the data is indirectly. So potentially the indirectness is create the problem. If you are taking only small group of population, only English published articles, in particular this one a region only, there is a direct evidence that will generate direct evidence. But when you are pulling data from across the studies, different populations, right? There is a potential indirectness will be there, right? How I address the indirectness? Just I will give you a small example that PCOS is the answer for the indirectness. If you are including the participants, right? If the studies include the participants of all the age group, but few studies will be having the 30 to 60, 80 years, or elderly population, or a smaller age group. So this factor out the indirectness. If you have multiple groups of the populations, the indirectness will increase. If you have the particular group only adult population from 18 to 60 years, then indirectness will not be there. But if you have elderly population group and you have the smaller age group and also middle age group, so that brings the indirectness, right? Second thing, intervention. What are the intervention problems? There are like multiple, see nothing like a drug like dapagliflozin, I cannot use only 10 mg. Dapagliflozin, I will start with the 5 mg, then 10 mg, if required, then further we add the another drug. Okay, adding group also. So intervention also varies actually, right? If you are having only single intervention, then indirectness will be less. But if you have multiple, then indirectness will increase, right? Similarly, comparator. There is active comparator will be there. There is a standard of care will be there. Or some additional interventions will be done. All these things will create the indirectness. So we have to observe, and depending on the indirectness, extent of indirectness, whether we downgrade it or not, right? So this is how we generally do while doing the grading. Because ultimately, when you do the grade, right, the outcome what you are telling is as like recommendations. So we should be confident enough to recommend something, seeing all this data. So you cannot blindly say that I recommend FCM over the IS in iron sucrose, right? Yes, you may sound good because FCM is once injection, 1000 mg tak de sakte, iron sucrose multiple injection. But you cannot directly say. You have to provide substantial evidence that a particular age group population of these patients will be having FCM is a better tolerated, right? Yes, ma'am. Yeah, that's what the madam is telling. Madam told. Inclusion exclusion criteria is not for the participants only, for intervention, for a comparator and the outcome assessment. You have to be clear cut. To be precise, then you get that direct evidence. You can generate the directness of the evidence.
Homogeneous.
More homogeneous. But as you are taking secondary data, potentially their indirectness will be there. And you have to minimize how much you can say, right? And you can accordingly, you can recommend it, right? Again, second thing is that as this, if you are not predefined it, we are excluding this patient that above 60 years I'll be excluding. If you are not pre-specified, but you are doing during your work, during your research analysis, that is wrong. It should be predefined, right? So these are the potentially how this age group like elderly, middle age, so ages, participation, everything will be comes the indirectness, right? So I just skipping this one. Then comes the imprecision. There are 4 terms I am telling again. They are like a sort of tendency to forgetness will be very high. Risk of bias, right? Inconsistency is for the heterogeneity. Indirectness is because for PICO, participant, intervention, comparator, outcome. इतना तो याद हो जाएगा ना? Then imprecision. Precision मतलब क्या होता है? The bigger the size, small precision होता है. Simple सी है ना? Right? It is about the sample size. How many patients you pull the data? Right? That is important for the imprecision. Right? So imprecision in generally we say that, but dichomatous data is around 2000 per group. If I am doing a case of like mortality in cardiovascular diseases, right? Dapagliflozin in acute MI cases. If I am doing this study, the study published to 3,000, 6,000 patients, right? And the outcome is death and no, right? Simple. So dichomatous data. So in such cases, we need to have bigger, direct continuous, we need to have smaller size, right? 400. So this is called the actually optimal information size, OS. If it is available and you are meeting the criteria, then downgrade it. Will not downgrade. If it is not meeting, then you can downgrade accordingly, right? And the second one is that something contextualized, right? If the effect size is bigger, whatever you observed effect size, after pulling the data, effect size is good, favoring towards the intervention strongly, then we may not go to downgradation of the recommendations, right? So based on the outcome of the study. Just information, I'll just tell you for 2 minutes, right? Right. Here, there is here if you see the outcome of the data, around 2.2%, right? This is around 2.2%. It means around 22% death reduction will be there in steroids in sepsis, right? This is strong, right? In sepsis, if you use steroids, 22% chances of lesser death in that group is there. It's a strong recommendation. But however, if you see the confidence interval is touching towards the null hypothesis, right? So if it is touching towards the null hypothesis or near the minimally clinically effective, that crossing that one, then we generally downgrade by 1 point. That is, sir says that ki, yeah, 5% का तो इधर उधर हो जाता है. Sir, now intensivist says that ki, why we need clinician here? This is what I am telling. We need in a team, we need a clinician because he will tell 5-10% को हो जाता है यार, इतना उतना difference हो मतलब apparently होता है. So we tell that minimally clinically ineffective when it crosses above 5% of death. If my confidence interval lower side is touching across or it is crossing that one, then I would downgrade by 1 point. If it is not crossing, then I will not downgrade further. If it is crossing the null hypothesis, then I will downgrade by 2 points. If larger the effect, then I will not downgrade. Smaller effect, but it is touching towards the minimally clinically beneficiable, then I will downgrade 1 point. If it is the confidence interval is touching the null hypothesis, then I will downgrade by 2 points. I cannot say that confident. I cannot be confident, right? Because already वो null hypothesis को cross कर रही है. So how can be a confident that के steroids use करो? So I can say I will not be confident, right? So finally, if I do all these things, I will be getting the grade table, and the grade table is level of evidence are high, moderate, low, or very low. Based on that, it is a highly likely that intervention will be favorable. It is likely, then possibly, then not clear. In case of possible and not clear, generally we recommend that there is a need for bigger studies with greater sample size and adequate what is the indirectness what we have generated. That is in a fixed population group with fixed intervention and high quality study, the risk of bias will be there. Inconsistency or heterogeneity that can be addressed and indirectness will be addressed and sample size inconsistency will be or imprecision will be addressed. So like that we recommend. So overall what we get, this is what grade table will be getting, right? So here I am telling you that risk of bias, you can see in the third column, there is a serious. Why I downgraded here, this is my study only, it's recent published. So this is serious because there are particular studies having high risk bias. That's why I downgraded by 1 point. Inconsistency I didn't, indirectness also I didn't, but for imprecision I downgraded by 1 more point. That resulted in the overall outcome is only low level of evidence, right? And the second one is the last one, that is response rate. Here I downgraded by right this one progression-free survival. There also I downgraded by 1 point for one reason, that is imprecision because of sample size. Other areas the outcomes measures are like risk of bias, inconsistency, and indirectness are good. That's why I generated a moderate grade of evidence, right? And the second table what we get is summary of finding table. Summary of finding table में हम यही बताते हैं कि कितना benefit हो रहा है and कितना confident हो. That's what I am telling here. See, the hazard ratio is around 0.62. That is, we can 38% mortality or the survival will be there with a confidence of 0.5 to 7.6. And a certainty of evidence is around high certainty of evidence. That's how we can comment, right? So this is all about the risk of bias and grade evidence. Okay. In general, if you are first time you are listening, I expect that at least there are 3 components of risk of bias from the 5 different domains, right? And these biases are mainly about the selection bias, performance bias, attrition bias, outcome assessment bias, or reporting bias, right? Detection bias. These are the 4 components that we generally look into it and we come out, right? These are my recent publications. Just for your information, I have a Cochrane review and I have some systematic reviews also and also other reviews. And you can see, सर आप तो हाइपरटेंशन में भी काम कर रहे हो, ऑस्टियोपोरोसिस पे काम कर रहे हो, ये भी कर रहे हो, वो भी कर रहे हो, ये भी कर रहे हो, क्या है सर आपका कंसिस्टेंसी नहीं है? My consistency is systematic review meta-analysis, not the domain, right? Thank you. Any questions, please? Yes.